So good morning. So we are now 24, sorry, 24 participants in audience, isn't it? And I think the MR class, the basic understanding of MR, if I describe the how to report or how to read an abdominal MR, it has to be interactive. Otherwise, like you may miss something, some important practical points which would be required for your diagnostic point of view uh, when you really try and understand what is going on inside MRCP film or upper abdomen triphasic MRI. You need to know basic sequences and what is the normal anatomy and what is the pathology, right? So just hold on for a moment. So if we start off slowly and we will discuss the images on a case-to-case basis, it would be helpful for you. So is it okay? Anyone would answer?
So your screen is not visible, sir?
No, I have not shared my screen.
Okay, sir.
So can you hear me now?
Yes, sir, you're clearly audible.
All right. So basically, if I start off with the basic MR imaging of abdomen, and one more thing, you please let me know. You are interested in body MR, isn't it? So how frequently you encounter a brain MRI brain? Anyone from your side? You see any you read MRI of brain and you need to know what is the sequences in brain or only
Brain MRI normally we don't come with. We just come with Mrcp or MR whole abdomen.
correct. That's why it was my thinking that we need to concentrate on the abdominal MRI, isn't it? So in abdomen there are few important things like for your surgical point of view, you have to read MRCP sequences. That is very important. MRCP gives you an idea whether whatever is the report, you need to know if the patient is having jaundice, upper abdominal pain. You need to read that film. So whether the patient is having cholelithiasis, whether this pain is due to acute pancreatitis or it is due to choledocholithiasis with resulting biliary obstruction. So I think now you are well conversant with the axial CT scan reports, CT scan films. You have seen the CT scan pictures. Now I'll just show you one image of CT scan as well as MRI. You see and you let me know. So what is the difference between CT image and MR image? Okay. So would someone tell us which of these images are CT scan and which of the images are of MRI? All right. So the upper two sections, can you see my cursor?
Yes, sir, your cursor is visible.
The audience who is going to or whoever is comfortable with interactive session, keep yourself unmute. Okay. You can talk to me. You can clarify your issues, your questions. Then I'll be it has to be an interactive one, right? Otherwise, showing few MR scans and showing this is that, it won't help you much. So in this particular case, you see these two pictures are of CT scan, right? Why it is CT scan? Because you know it is CT scan. The texture tells it is CT scan. In CT scan, the bone is bright. This is the lumbar vertebral body is bright. All these lower thoracic ribs are bright, means white. These are white. This is a contrast enhanced study. This is a contrast enhanced study. That's why the aorta, this is aorta, it is so white, right? There are few arteries adjacent to, this is the porta hepatis area. So this is probably the left hepatic artery. This is splenic artery. All are taking contrast and appears bright or white. This is spleen. This is spleen. Sorry. And spleen in different phases of contrast study, it appears differently. So if you see the spleen is having a bit heterogeneity, that means it is not homogeneously enhancing. Don't bother that, because in arterial phase spleen will be heterogeneous, but in portal venous phase or hepatic venous phase it will be homogeneous. Okay, so these two are the CT scan images where you can see this as a liver. So you can see my cursor, I believe. Can you see my
Yes,
cursor?
sir.
Okay,
Yes, sir.
fine.
Cursor is visible.
Yeah. So I just wanted to screen use presenter view. All right. So this is liver, and liver is having some parallel areas of hypodensity. Here is the hypodense areas are there. Here in this particular scan also you can see the hypodense areas are there, and there are few bright or hyperdense, that means white areas. Some white areas are there, some black areas there. Can anyone tell us what are these black areas and what are these white areas?
The black areas are the bile content, and white areas are the arterial parts.
Well done, perfect. So these are the dilated bile ducts containing bile. Bile is hypodense, that's why see this is the stomach, and you see the fluid inside the stomach is hypodense. So that's the same density, or mostly the same density of the bile. So that's why both of these structures are hypodense. Whereas this arterial structure, after giving intravenous contrast, this arterial structures appears white. So this is aorta is white. So this must be some branches of the. Just Baba. Pratimadi. Really sorry for that. So where we were, yeah. So these structures which are hypodense, these are the dilated bile ducts, and these bright or white structures are the intrahepatic arteries. So is it a normal scan of liver, or it is the abnormal scan of liver? Anyone?
It seems abnormal, sir,
Why?
because the bile ducts are not so dilated normally, sir.
True. So perfect. So in normal study, in normal CT scan of liver, we don't see the hypodense bile ducts because they are actually collapsed. If there is no biliary obstruction, so bile ducts will not be dilated, and we will not see this type of dilated hypodense track-like structures. So perfect. So there is some abnormality, and it is the dilated obstruction. Somewhere there is obstruction of the bile ducts, ductal channels, and intrahepatic biliary ducts are dilated. Perfect. So these two are CT scan images. Just the lower two images, if you see, you can see just the mirror image of the texture, or what the color composition. What you can see in the gray shades in the upper two images, the bile ducts are hypodense in the upper two sets of images, where the aorta is bright, but in lower sets of images the bile ducts are bright and the aorta is dark. Just the opposite. You see in the upper images the vertebrae are bright and spinal cord is hypodense. Here in the lower images, the vertebral bodies are hypodense, hypo is black, and the spinal cord is bright. So now you can understand these two images are these four images are not CT scan images. The upper two images are CT scan image, and the lower two images are. Can anybody tell us which sequence is this? So this is MRI sequence, MRI T2 weighted sequence. Now coming to the basic sequences in MRI, when you see a MRI film of a patient, you will see lot many images of different combination of shades of gray. Here, the lower two images are the T2 weighted images, where the fluid containing structures would appear bright. So the fluid inside the bile ducts, the fluid inside the spinal canal appearing bright or white. Here on MRI, when something appears bright, we call it hyper intense. So it is actually the nomenclature changes. It changes from when you see a bright structure in X-ray, you say it is radio opaque. Whereas the same hyperdense structure or same bright structure in CT scan, you call it is hyperdense. And if you see any structure is bright or white on MRI, you call it hyperintense. Okay, so when you read the report, you will see this type of different nomenclature we use when we report a CT scan or MRI. Similarly, when we see a lesion in ultrasonography, and when it appears bright, that like gallstone, when it appears bright, when we call it hyperechoic. So radio opaque, then on ultrasonography hyperechoic or hypoechoic, on CT scan hyperdense or hypodense, or sometimes we call hyperattenuating and hypoattenuating, and on MRI hyperintense and hypointense. Okay, it is not necessarily all structures which are hyperdense on CT scan would be hyperintense on MRI. Here are the difference between these two imaging modality. Like in this particular case, this is T2 weighted sequence, where you see the dilated bile ducts appears as a bright, and spinal canal fluid inside that or CSF inside the spinal canal appears bright. But in T1 weighted image, you would see all these structures are hypointense, similar to that structures, similar to the intensity we see in CT scan. So there are three basic sequences on MRI. We call it spin echo, gradient echo, and inversion recovery. But I don't think you need to go inside that physics, MR physics of those different sequences. You need to remember three sequences. When you are dealing with abdominal MRI, it is T1 weighted image, T2 weighted image, and the Haste sequence. Haste is the heavily T2 weighted sequence, which are meant for seeing the bile duct structures or biliary tree very clearly. Haste sequence. So the lower down two sequences are the T2 weighted sequence. If we scroll up here, in this particular case, you can see the whole picture is covered with grossly dilated and tortuous bile ducts. So now to start with, it would be difficult for you to interpret which ducts are coming from which segments. But I would tell you something. If you see, this is liver. This entire thing is liver. We have just zoomed in the liver and we can see all ductal system. So this is the left lobe. Okay. So just I want to get the cursor. So pointer option, pen color, right. So if you see an Mrcp sequence and if you divide the liver into two segments, so this is the left lobe of liver and this is the right lobe of liver. In the left lobe, the ducts which are coming from below, the inferior aspect here, this is segment 3, and which are coming from above, this duct is segment 2. In left lobe, this is segment 2, this is segment 3. There are few ducts, the small individual ducts, they are draining into the directly proximal left hepatic duct, like this duct, and this duct. This is from segment 4. The superior segments are called is called segment 4A, like this, and see this duct is draining from below, and this is segment 4B. So left lobe, the lateral the medial aspect of the left lobe comprises of the superior lobe segment 2 and 3, and laterally it is segment 4A and 4B. Now coming to the right lobe. Right lobe, there are 4 segments, and you need to know the posterior segments are more horizontal and the anterior segments are more vertical. Like usually, I'll tell you in some other sequences as well. Usually the posterior sequence is this, coming like this, right posterior sectoral duct, and dividing into segment 6 and segment 7. So this is 7, this is 6. Whereas the right anterior sectoral duct course vertically like this. Here these are the superimposed images, so you may not define it very clearly, but for my discussion point of view, let's assume that this is the right anterior sectoral duct, and it is going to the segment 8 like this and segment 5 like this. So usually the 7 and 6, they are occupying the lateral aspect. So probably this is the area of 7, this is the area of 8, this is the area of 6, and this is the area of 5. The lateral aspect of your right lobe, the right posterior sectoral duct is horizontal, whereas the medial, the anterior and anterior sectoral ducts is coursing vertical and dividing into 8 and 5, which are more medially situated. Now coming to another example, like this. In this particular case, you can understand this is a MRI picture of a patient having hilar cholangiocarcinoma with separation of biliary ductal confluence. Here you could see the right and right duct, so here this is the right sectoral right hepatic duct, this is the left hepatic duct. They should have joined here and formed the biliary ductal confluence, and then common hepatic duct, and then somewhere here the cystic duct would join, and then the common bile duct draining into the ampulla. So this whole area, we cannot visualize that biliary ductal confluence and common hepatic duct here. We can see a faintly mid and distal common bile duct. So there is a lesion at biliary ductal confluence separating the right and left hepatic duct. So this is the left duct. Again, this is segment 3, this is segment 2, and these smaller branches are draining in proximal left hepatic duct. These are from segment 4. Some of the segment 4 ducts also drains into the proximal right hepatic duct as well. And in the right side, the duct which is horizontal, it is the right posterior duct dividing into segment 7 and segment 6, and the duct which is more vertical, it drains into it is the duct of segment 8 and segment 5. So more or less on MRCP, if you see a lesion and you need to characterize the lesion, the medial inferior is segment 5, lateral inferior is segment 6, lateral superior is segment 7, medial superior is segment 8. Segment 4 is almost there are multiple individual ducts draining into the proximal left and right hepatic duct. This is segment 2 and this is segment 3. So is that clear? Anyone from the audience?
Yes, yes, very clear.
So, so basically, this sequence is called the Haste sequence. You need to remember the Haste sequence, or if you cannot remember it, it is heavily T2 weighted sequence. As I told you, the T2 weighted sequence, in T2 weighted sequence, the fluid containing structures appear bright, as I have shown in the previous slides, where the dilated bile ducts were bright or hyper intense or white looking on axial section. But we could have seen the other structures like the liver, uh, the spleen, stomach, vertebral body, the rest things we could see on that axial image. So that is T2 weighted, and this structure is heavily T2 weighted, means we can only pick the fluid containing structure and nothing else. See, in this particular picture, you merely see anything else from the dilated bile ducts. You cannot see liver, you cannot see any other structures, only the bile ducts which are dilated, and this is the stomach which contains fluid. Again, it contains fluid, that's why you can see the bright shadow of the stomach. So here this sequence is meant only to see the biliary tree and nothing else. So here we can see the exact location of obstruction, the cause of obstruction, whether it is neoplastic or it is due to choledocholithiasis or something else, or any inflammatory lesion which is causing that, we can see and figure out in this T2 weighted sequence, which is called Haste sequence. So these were the normal T2 weighted sequence. These are the CT scan, corresponding CT scan images. This is T2 weighted sequence, and this is the Haste sequence. All right. Now coming to few important lesions which are so here in this particular case, in this particular picture actually, can anyone tell us this is normal or abnormal? And first of all, which sequence is this?
Someone
So
can
again,
answer. Someone
yeah,
can answer.
Haste sequence.
exactly, perfect, well done. So this is the Haste sequence. This is heavily T2 weighted. We can only see the fluid containing structures here. So can you see what are the what is this structure? See, the stomach rugosities are there. So this is the stomach. All right, and this is
biliary tree.
biliary tree. This is common bile duct. This is the right branches of the right lobe of liver having dilated intrahepatic biliary radicals, and this is the left lobe of liver. So we can see the dilated intrahepatic biliary radicals. We can see the dilated CBD. This is the gallbladder, which is grossly distended, and this is the dilated pancreatic duct. Okay, in its entire course, pancreatic duct is dilated. These are the jejunal loops here, you can see. So and this is the area of duodenum. Here it is duodenum, where both the ducts should join and drain into the second part of duodenum at the level of ampulla. So do you think it is normal or abnormal?
Abnormal, sir.
Abnormal.
Why? What told you this is abnormal?
Because the extrahepatic
Duct is
biliary
dilated.
tree is dilated and MPT is also dilated.
Perfect. So both the system, like the biliary system and pancreatic ductal systems, are dilated. They are not merging. Like the distal CBD is not joining with the pancreatic duct and forming a double duct sign, what we call double duct sign. Both ducts are dilated and they are separate from each other. None of these ducts are draining into the ampulla. So there must be a lesion at the periampullary region. Either it is a periampullary pancreatic head mass or duodenal carcinoma, isn't it? Or some distal CBD cholangiocarcinoma, which is infiltrating into the pancreatic duct and causing its obstruction. So I told it would be absolutely interactive, and I would only show few interesting cases of the hepatobiliary and pancreas region, where you need to tell me whether it is normal or abnormal, and if it is abnormal, what is the pathology? Only this much, and at rest I would tell you. Here in this slide, there are 4 sequences, right? On the left side, 2 sequences are the contrast enhanced sequence. On the right side, both the sequences are non-contrast scan. Can anyone tell us which is CT scan and which is MRI? Which are MRI?
So left side upper CT scan.
Well done, perfect. And this sequence is MRI. And can anyone tell us which sequence is this? Like in MRI, it is T1, T2, Haste sequence, contrast enhanced.
T1, sir.
T2 sequence.
This T2 sequence. Perfect. Perfect. Like, why? Because I told you, when you see a MRI of abdomen, you would see the structures containing fluid, like stomach, spinal cord is a consistent area where you can see and you can figure out which sequence is this. The spinal canal containing CSF, which is bright here. This is gallbladder, which is again bright, and this is the dilated left renal pelvis, which appears bright, hyper intense. So this is T2 weighted sequence. And this is CT scan. This is T2 weighted sequence. This is in coronal plane. This is axial plane, and this is coronal plane. Again, this is very important on MRI. You would have a multiplanar imaging. In CT scan, with the advent of our high detector series like 128 slice or 360 slice CT scan, even from 16 slice CT scan, what we see on CT scan is a orthotopic, we call it, is a volume image. The volume data are acquired if the CT scanner is having slice, the rows of detectors 16 slice or more, where we get data of sub-millimeter thickness. We take the data from the whole body, and the slice thickness would be less than a millimeter. So if once we grab the data, we can see that data set in various different planes. Like if we see the coronal, the image in coronal plane or sagittal plane or axial or in different oblique planes, the volume would be same, and you would see a exact 3-dimensional picture of the whole abdomen. So that is the beauty of CT scan. We can take sub-6 millimeter data. So it is a orthotopic image in any plane. Once we grab the data, the axial plane, the resolution of axial plane, coronal plane, sagittal plane would be the same, and it would be the whole volume data. So we can see the 3-dimensional picture as well. Whereas on MRI, we cannot do that. So that's why we have to take different, we have to acquire the data set in different planes. Like the same sequence, T2 sequence, we do in axial plane, in coronal plane, sometimes in sagittal plane. Because from this data of axial MRI, we cannot we cannot extrapolate the data of the coronal or sagittal images. We have to take the separate sequence for that. Is understood? In CT scan, we take volume data. It is sub-millimeter level thickness data we acquire. That means we take the all data from the whole abdomen. We grab in a breath hold of suppose 10 seconds or 15 seconds. So we can manipulate in whichever direction we want, like in sagittal, coronal, in oblique, whichever direction we want. We will see the resolution of the images would be the same. But in on MRI, we are not so fast. So if we take the axial scanners, we cannot extrapolate the coronal or sagittal images from this axial images. So we have to take those image sequences differently. So this it was the T2 weighted axial, this is T2 weighted coronal, and this is the post contrast. I mean, after giving the gadolinium, we have taken this image. This is post-contrast MRI. Usually, post-contrast images are taken on T1 weighted sequence. You remember. Two things you remember for exam point of view. In CT scan, we give iodinated contrast. Earlier, we used to give the ionic iodinated contrast, but now we give non-ionic iodinated contrast. Because iodine is radio dense, we can see on CT scan, if we give iodine, the structures containing the iodine containing molecule would appear bright or white. So this is the contrast for X-ray and CT scan. This is the iodinated contrast, non-ionic, to reduce the reaction, anaphylactic reaction in our body. Whereas on MRI, the contrast we use is called gadolinium. Gadolinium, again on post-contrast MRI, it would appear as bright. So this is the post-contrast sequence showing the aorta appears bright, kidney to contrast, and you can see the renal artery which are bright. So this is the post-contrast study. And at this point in time, I would tell you, we have something called microbubble in ultrasonography also. Even nowadays, it is not very popular in India, but in Western world, many center does routine contrast enhanced ultrasonography using the microbubbles. They inject a solution containing microbubbles, and inside the body, they generate multiple microbubbles. And when we see a specific lesion, like in liver tumor, the enhancement pattern, like it is enhancing on arterial phase, washout on portovenous phase, we can record the whole event in a real-time manner, and it is very safe. It is a bit costly, so that's why it's not very popular in India. And it is very much operator dependent. When you do the study and give the injection, it is one time, it is real time. You see and record it. If you cannot see, if the patient is not able to hold the breath, so your study is gone. So few issues are there. That's why it's not very popular, but it's very popular in the Western world, the microbubble contrast for the ultrasonography. So here we use the iodinated contrast for CT and X-ray, and the gadolinium for the MRI. So in this picture, can you identify any lesion, any abnormality, or it is a normal study?
No, sir.
I can't hear you. Please repeat.
Sir, it's not normal.
Yeah. So where is the pathology? Where?
Here, I think it's pancreas. Don't know. This
Yeah, absolutely
liver.
right. Well done. This is a pancreas. Absolutely, it is outside the liver. So this is the liver, right?
Yes, sir.
So it is a mass
this is
here.
the-
This is a mass here. See, this is the second part of duodenum. It is pushing the second part of duodenum laterally. The rest of the pancreatic neck anteriorly. This is the portal venous confluence. It has pushed medially. So this area is absolutely at the region of pancreatic head. This is the CT scan showing, but not sure. This is probably a solid mass lesion at the region of pancreatic head, not enhancing properly. It would be our report. Abutting the anterior cortex of right kidney, stretching duodenum, pancreatic neck, all structures abutting the inferior vena cava. This is the inferior vena cava, and abutting the portal confluence, although not encasing. To encase a lesion when on CT scan, if we see a lesion is encircling 180 degree of a vessel, then we call it is encasing the vessel. Otherwise, we call it is merely abutting it. So it is less than 180 degree, so it is abutting this portal confluence. But on MRI, if you see, it appears bright as the fluid structures inside the gallbladder or spinal canal. So although on CT scan, this is the beauty of MRI to characterize the lesion. The CT scan showed a hypodensity, non-enhancing mass lesion, not sure. I don't know, probably not, because if you see more and more cases, you will be finding that a big mass causing not much liver metastasis or not that ugly looking, not encasing those critical vascular structures around pancreas. And it should not be pancreatic adenocarcinoma. It should be someone who is more dormant type, like more benign type of tumor. So, but you're not sure whether it is a solid or cystic. But on MRI, you see it is a purely cystic lesion. Rather, it is microcystic lesion with multiple internal septations, multi-loculated lesions, all locally are less than 2 centimeter. Again, in this picture, you see the thick peripheral wall, multiple internal cysts, small dot of calcification inside. So it is a microcystic lesion involving the pancreatic head. And if I say it is a elderly male, so what would be your diagnosis?
Yes, sir. Say head of pancreas.
Yeah, it is not an adenocarcinoma. It is a cystic lesion. I told you this on T2 weighted image. It is cystic lesion. So it is a cystic pancreatic neoplasm, and it is actually microcystic. Multiple microcysts are there with central area of fibrosis, tiny calcification. So this is serous cyst adenoma. Okay.
Okay, sir.
And similarly, again, I would tell you that there is another lesion, a big thick walled cystic lesion at the region of pancreatic body and tail. This is the pancreatic head and proximal body, where you can see the non-dilated pancreatic duct here. And on Mrcp sequence or Haste sequence, you can also see this is the pancreatic duct, which is not dilated, and there is a thick walled unilocular cystic lesion at the region of pancreatic body and tail. The lesion has got a small eccentric soft tissue mural nodule. And on this contrast enhanced study, this is the contrast enhanced scans, you could see the nodule is enhancing as well as the enhancing wall of the unilocular cyst. And there are multiple deposits in liver, both in segment 3, 2, and segment 7, multiple deposits. So this is another pancreatic cystic neoplasm, and it is called mucinous cyst adenoma. Here it is a case of mucinous cyst adenoma carcinoma with multiple liver metastasis. Okay, so you would likely to get this type of images. You need to see this image and tell us this is T1 weighted, T2 weighted, or which sequence is this, and which sequence is this, and which sequence is this. Can anyone tell me what is this sequence?
T2, sir.
This is T2 weighted sequence. Why? The
So
fluid
because fluid is white.
is white. Exactly. The fluid is white. The gallbladder is bright. The spinal canal CSF is bright. Small dot-like structures are there inside. This is the nerve roots, okay, of cauda equina. And what is this sequence?
Haste sequence, sir.
Haste sequence. See, only you can see the fluid containing structures here, nothing else. And this is?
Contrast.
This is the
T1
contrast
weighted with
enhanced
contrast.
T1. Exactly. Why T1 weighted? Because see, the CSF is black, the fluid is black, hypointense, but all the contrast holding structures like the arteries, this is aorta, this is the celiac trunk, this is the inferior vena cava, this is the portal vein, all are bright, and those tumor component also enhancing. So this is the contrast enhanced T1 weighted image.
Anything in the spleen here?
Yeah, so there are multiple lesions in the spleen, but as I told in that earlier CT scan image, the spleen, to diagnose a lesion in spleen, you need to see different post-contrast images, different post-contrast sequences, because in this is probably the artery is very enhanced, the aorta is containing contrast and it is very bright. So it is probably the arterial, late arterial or portovenous phase, because the portal vein has also got the contrast, IVC is also having the contrast inside. So here sometimes we may get this type of patchy, because the splenic pulps are they are very heterogeneous in taking contrast. So probably there are few lesions are there in spleen, but here we can only say there are few lesions in spleen. These liver lesions are definitely metastasis, but to say these splenic lesions to be metastasis, we need to see the other sequences like see, we have, I told in my previous class, like we have a early arterial, late arterial, portovenous phase, hepatic venous phase, and everything is applicable to this MR as well. The same thing, the post contrast regime, what we follow in CT scan, same thing follows in MRI. In MRI, we take few sequences more, like see in when we use liver scanning, usually we give a contrast called gadolinium BOPTA. This is very much liver specific, multi-hands, and in that scanning we do a late arterial phase, portovenous phase. Portovenous or hepatic venous phase is around 50 seconds phase, and then a equilibrium phase. This is very important. Equilibrium phase is 90 minutes from the starting of giving contrast. So it was like, first we take a 25-second scan, then 60 to 80-second scan, then 120-second scan, then we take the patient off from the MR gantry and give him breakfast or something, make him comfortable, and after 1.5 hours, it says in between 1 to 2 hours, we take it in at 1 hour 30 minutes, we take an equilibrium scan where the gadolinium, the hepatic distribution of gadolinium is uniform in equilibrium phase of contrast study, which is 90 minutes from in between 1 to 2 hours of giving intravenous contrast gadolinium, which is liver specific. It is only can be done with a liver specific gadolinium, not using any other contrast would give you these results. And in this specific equilibrium phase, you would see the whole liver would be homogeneously enhancing, and the lesion which stands out, which is not a hepatocytes containing lesion, which would stands out. So sometimes seeing the arterial portovenous phase or the delayed images, you would not be very sure whether this lesion is biphenotypic, means it is a ISCC, a hepatocellular carcinoma and intrahepatic cholangio combination, or it is purely ISCC, or in something else, or you may miss some smaller metastasis in normal span of study, because the liver would not be that homogeneous enhancing. But in 90 minutes scan, you would see the lesion which is not containing hepatocyte would stand out. So that is a very important thing, and you need to know. Actually, sir, I need to go because I have a emergency OT and CMRI.
Okay.
So I think today I'm stopping it 10 minutes before.
Okay, fine. No problem.
And see, first of all, understanding MRI would be a huge thing. Like in abdominal perspective, I tried to figure out those things which would be mostly useful for them, the students, like the surgical students who need to see the Mrcp, the T1 weighted sequence, T2 weighted sequence, and the Mrcp sequence. And in Mrcp, I would tell you something which is, the last slide would be showing some choledocholithiasis. See, this is gallbladder on ultrasonography. This is the gallbladder stone, how it look like, the gallbladder stone. And here, this is the CBD stone on ultrasonography, right? In ultrasonography, again, the fluid is black, the stone would be brighter. So the fluid is hypoechoic or anechoic. I told you, echogenicity, say, we will correlate with the echogenicity. So it is hypoechoic and the stone is bright or hyperechoic. If you see on MR here, so this stone is the ultrasonographic image visualization of the stone, which is bright or echogenic, and this is the MR counterpart of the same stone. It's not the same patient, it's all are borrowed from the literature. And here you could see the in Haste sequence, the fluid containing structures are bright, and this small hypointense stone is very clearly visualized on this Mrcp or Haste sequence. So this is pancreatic duct, this is the common bile duct, this is gallbladder, this is duodenum, and this is the intrahepatic biliary radicals. So in Mrcp, when you see a stone is there, your job is not completely done. You need to see the pancreatic ductal anomaly, you need to see the biliary ductal anomaly, and the drainage of the cystic duct. When you are planning for suppose patient is having cholelithiasis and choledocholithiasis, I need to tell you whether the cystic duct is low lying or its location is normal, whether there is any accessory right hepatic duct present or not. You may miss it is in colors. When you open it, you should be very careful when you see and clamp the cystic duct. You should not clamp the accessory right hepatic duct and all these things. So, and is there any pancreatic ductal anomaly present or not? All these things, I think I need one more class down the lane to describe all these things.
Sure.
Okay,
We will
sir?
have 2 more class, one for rectal MRI and other for abdominal.
All right, sir. All right, sir.
Yeah.
So thank you so much.
Thank you.
Thank you all. Have a nice day.
Yeah. 10 minutes time. We have other teachers present here. Dr. Maiti, Dr. Ghosh. We can have some discussion. Dr. Bhattacharya is busy.
Thank you, sir.
Yeah. Thank you, Dr. Bhattacharya. Dr. Maiti, any comment?
Actually, MRI, regarding if we compare MRI and CT scan, still CT scan becomes it's more friendly. It is easier to study to a surgeon. Or MR pictures are really very difficult to study in most of the time, except probably in case of Mrcp, where the biliary tree is very nicely visible. But in case of brain, spine, and other things, other places, it is very difficult. And I think in next class, Dr. Ovirup, Dr. Bhattacharya's explanation will help me also a lot. That's comment I can. Sivajyoti is there. Sivajyoti is a master on those things. Sivajyoti.
Dr. Ghosh. Audio. Dr. Ghosh, any comment?
Another thing regarding MR fistulogram, that is unique. That helps a lot in understanding the course of the fistulae, perianal fistulas. And that is a very, very fantastic armamentarium to the radiologist, and that helps the surgeon a lot.
Actually, Dr. Maiti, the problem with us is we are not very conversant with MR anatomy. The way Dr. Bhattacharya explained, now if you know that this is the course of segment 3 ducts, this corresponds to segment of 4 ducts, you can exactly make out the site of fusion. In CT, we are little more conversant because we're seeing a lot of times here CT scan. But if you know the MR anatomy, this MR gives you a more pinpoint area of lesion, particularly soft tissue lesions. So that way MR is very good, but problem is we are not seeing regularly and we are not conversing in the MR anatomy. Dr. Ghosh, any comment?
Hello?
Yes.
Hello?
Hello,
I'm Bhattacharya.
Yes.
I was enjoying the meeting with my wife, as my wife is radiologist, you know.
Yes.
Oh.
I've been listening to the Sukumar Das statement and your statement and other statement. Let me tell you one thing. When we were medical student, 84, 85, then we had only ultrasound, nothing else. In 90, when he completed, we see the CT scan machines in the city of Calcutta. Then later on the MRI came. What Sukumar Das is saying is absolutely correct. More we see the plates, more we become conversant. The summary is, more we see the plates, more we become conversant. Now the younger generation students, those who are medical student and doing a master's in surgery, they should visit the radiology department with X-ray plates more frequently. That is the only solution. And a multidisciplinary meeting with the radiologist will make them more conversant. So that is my suggestion. What I do, I always bring my plates at my home and see at the night before I go for operation. And then I know, with discussion with my wife, I know what is the resectable lesion. Most important thing to the surgeon is from the CT, MRI and all these studies is whether the lesion is resectable or not. Should I go into the abdomen or should I not? And or should I opt for some other treatment like chemotherapy or radiotherapy or these are the things which absolutely gives you a telltale sign. The CT scan with a good radiologist will tell you, Dada, don't do this operation, this has got a spread. So this is very important, and we have to heavily the other organizations like Tata and Bombay, they do all these things and they do not operate unnecessarily. So our aim is in oncology and in hepatobiliary surgery and in stone disease. Nowadays, many endoscopists do not do ERCP on the basis of ultrasound. They always look for a MRCP plate. They all, because this is ultrasound is operator dependent and MRI is a document, which document is permanent document and which everybody can see. Even if after 6 months there is a controversy, we can go back to the old plates and see. So these are the advantages, and my request to my juniors is try to visit frequently the radiology department and see these plates with the radiologist. So you will be conversant. The thing what I follow and what I have seen in multidisciplinary meeting in different countries. Thank you. Thank you.
Dr.
Ghosh,
Bosak,
any comment?
Dr. Bosak, actually, my basic knowledge, if you want to study a solid structure with precision, ask for CT and with contrast CT. And if you want to study the ductular structure or a cavity, particularly the spine, etc., MRI may be better. I don't know whether it is true or not.
Hello, hello. These investigations in the radiology department is evolving, as I have told you, and now what I find that the MRI is gradually taking up the place of CT more frequently with their more types of weighted images, and T1, T2, Haste, fast suppression, and all these things are coming up. MRI is also improving, so we have to also improve. And you are absolutely right. Now I feel in the hepatobiliary region, the MRI is better, because if you want to see a gallbladder carcinoma or for operability, because there are 3 ductular structures. One is the portal vein, one is the bile duct, and one is the hepatic artery, right and left duct, and all these things are telltale visible in the MRI plate. And whether there is invasion into these structures and lymph nodal structures, because these are all soft tissues. So my personal feeling is gradually MRI images will replace the CT scan in the gallbladder. And like rectum,
standard teaching is for soft tissue lesions, MRI is scoring better than CT scan. For any rectal carcinoma, any soft tissue sarcomas, the MRI is scoring for CT scan. Because the problem was our interpretation problem. Now you have radiologists like Dr. Avik Bhattacharya, they can give you very good delineation of things. So the basic standard teaching is for soft tissue lesions, MR is better than CT.
Yes.
I just want to make one comment here.
Yes. Yeah.
Just modifying Dr. Bosak's statement. Instead of along with the CT plates, I think nowadays, if we ask for the pen drive or CD, this can easily seen in our, laptop computers or our desktop computers. We just need to download one DICOM viewer software from the internet, which is free. And if we just put in the CD or pen drive over there, we can see lots of frames in this pen drive or CD drive that is given, and from there also we can have our, we can learn a lot of things from there. It's like seeing ECG every day. So if we just ask for the CD drive or the pen drive instead of only the plates, and we try to read all this CT scan ourselves, or the MRI. Even the MRI can also be given in pen drive. So from there we can just we learn a lot of things from there.
Professor Ghosh, please repeat the software.
That is DICOM viewer.
DICOM.
Yeah, DICOM, DICOM viewer, which is available free in the internet. You just type DICOM viewer in Google and you will see the software there, and just download it. It's a very small software, but very, very useful.
You can see the picture in sequence. which is not there in the just in a plate. You cannot
Yeah.
make out that
So,
sequence.
and also we can make out from axial view, we can just convert the axial view into coronal view or sagittal view, and we can also reconstruct the arterial things, 3D reconstruction of artery from that software. It's a very nice software. So we just need to handle that software. Maybe 2 or 3 visits in the radiology department. Just find out one good PGT who will teach you all how to handle this software, and from there we can reconstruct ourselves and we can learn a lot of things. In fact, in our unit we are doing this very regularly, and all our PGTs, I'm very proud to say that all my PGTs so far, they read CT scan better than me.
Yeah,
One
that
thing-
one should regularly keep on seeing the plates, discuss with the radiologist. That is a better way for learning.
Yes. One thing I want to add here with Professor Ghosh's statement is that the MRI plates are the static photos taken from the console, MRI or CT, and the CD or the pen drive gives you the whole lot of dynamic picture. So that is the difference. And if you see that, and the MRI and CT plate usually give a plate of 0.5 millimeter, 0.5 centimeter, or in some centers 0.8 centimeter cut. So small lesions, which is less than 0.5 centimeter or 0.0 centimeter, may be missed in the CT scan. So it is better to see the CT plate or the pen drives, as Professor Sivajyoti Ghosh has said. So this is very important. Study this at home, and after you study, because as this is based on the basic anatomy of the body. So this is nothing MRI anatomy or things like that. If we know the anatomy, if we reconstruct, if we mentally visualize, because we have to visualize this regularly, and then our eye will be conversant. And we have to regularly visit the CT scan with a friendly doctor. They will teach you. Thank you.
Thank you, all senior faculties, and we have a lot of students today. We have a nice session. We will have 3-4 more session on CT and MRI afterwards. Thank you very much.
Thank you.
Thank you.
Thank you.
Nice class. Thank you.